बिस्मिल्लाहिर्रहमानिर्रहीम बिस्मिल्लाहिल्लज़ी ला यदुर्रु म'a अस्मिहि शै'उन फिल अर्दि वला फिस समा' व हुवस समीउल अलीम। शुरू उस बाबरकत नाम से जिसकी मौजूदगी में ज़मीन व आसमान की कोई चीज़ इंसान के लिए ज़र्र रसा नहीं हो सकती। खालिक कायनात और मालिक कायनात के बाबरकत नाम के साथ इब्तिदा करने से बरकत होती है, इसलिए हम उस बाबरकत नाम से शुरू कर रहे हैं। आज का टॉपिक हमारा है क्रॉनिक सपुरेटिव ओटाइटिस मीडिया। As it is apparent from the topic, it is the chronic persistent infection of middle ear involving the anteroinferior portion of the middle ear cleft by pus-forming organisms. A very common disease, and in ENT OPD you will find a large number of cases coming to you with persistent discharge and deafness in the ear. Most of the time these are cases of chronic suppurative otitis media. As the name indicates, it is infection of the middle ear cleft by pus forming organisms, and it has got two main types. One is tubotympanic and the other is aticoantral. Tubotympanic disease, which is also known as safe variety of chronic suppurative otitis media, in the sense that it does not give rise to serious complications. It's a chronic infection, persistent infection for years together. It can go on without causing any troublesome complications. That is why we call it safe variety. And in this variety, the perforation in the tympanic membrane is a central perforation. The second variety, that is aticoantral disease, which we also call unsafe disease, because in this type of chronic suppurative otitis media, there is not only infection of the middle ear cleft by pus forming organisms, but it is also associated most of the time with cholesteatoma, which we have discussed in the last lecture. It is a damaging disease causing pressure necrosis of the surrounding tissues, soft tissues as well as hard tissues. So let's discuss first the tubotympanic variety. Tubotympanic variety caused by pus forming gram positive as well as gram negative organisms, and when it becomes persistently chronic, anaerobic bacteria also take part in this process of infection. Patient might have infection with Pseudomonas aeruginosa or Bacillus proteus, which are relatively difficult bacteria to treat. Pathologically, the infection process is limited to the mucosa and anteroinferior part of the middle ear cleft. In this variety, the main stress of infection is in the anteroinferior part of the middle ear cleft, and in this variety there is no bony erosion by pressure necrosis, which is the criteria of cholesteatoma. In this variety it is not there. Most of the time the patient will be coming to you with the only symptom of deafness and discharge. Now let's discuss a little bit about the criteria of deafness and discharge. The deafness in this case will be conductive in type because there is central perforation. And if you perform tuning fork tests, in this case, you will find that the Rennie's test will be negative in the affected ear, indicating conductive deafness. And Weber test will be lateralized towards the affected ear. This conductive deafness can also be confirmed by performing various audiometries, and among these the pure tone audiometry is the commonest variety which we can go for, and it will tell you about the type of deafness and also amount of deafness. In conductive deafness, the patient also notes down the phenomena of autophony. By autophony we mean the patient listens his own voice louder than a normal person. That is why these patients, they speak usually in low tone, because they consider as if they are speaking quite loud, but because of this phenomena of autophony, in spite of the fact they are speaking in a low tone, they think that they are speaking quite loudly. So that is one criteria of these patients, that usually they speak in low tone. Now this conductive deafness, when the perforation in the tympanic membrane is small, it will be mild, maybe 10 to 15 decibels. But as the disease progresses and the perforation increases in size, it can go even up to subtotal perforation. In that situation, the patient will have more and more deafness. But this deafness, because of perforation of the drum, is usually in the range of 25-30 decibels, unless the ossicles, they also start damaging, or there is disconnection between the ossicles, then this deafness might cross 40 decibels. Discharge in this situation is copious in amount, is mucopurulent mostly, and there is no bad smell. That is the criteria of discharge in tubotympanic disease, as against the other variety which we will discuss just now afterwards, where the discharge is scanty, purulent and foul smelling. On examination of these patients, you will appreciate that there is discharge in the external auditory meatus, and as this discharge is copious in amount, you will also observe the phenomena of a reservoir. By phenomena of reservoir we mean when you clean this discharge, suck it out, or by dry mopping you remove the discharge, after some time again the ear is filled with mucopurulent discharge, as if there is some reservoir behind from which this discharge appears again after cleaning. This is what you call reservoir sign positive in these cases of tubotympanic disease, because the discharge is copious in amount and mostly it is mucopurulent or purulent sometimes. When you clean the discharge and have a look on the tympanic membrane, you will appreciate a central perforation. which I have just discussed, may be small or maybe more and more big, going up to the level of subtotal perforation. Oral polyp can also form because of granulation tissue formation, and it can appear in the external auditory meatus in the form of a rounded, reddish, smooth swelling, which may be visible to you, and you can see it in the picture. I'll just show you the picture. Have a look on this picture. There is a small central perforation anteroinferiorly, and you can also appreciate the congestion of the tympanic membrane and the blood vessels running over the surface of tympanic membrane. This is another picture which is showing you a big central perforation, and the ossicles are also visible to you in the upper portion of the middle ear. This is a picture showing you the tubotympanic disease in the middle ear cleft, and have a look on this yellowish shaded area in the anteroinferior portion of the middle ear and in the eustachian tube, indicating that main burden of infection in tubotympanic disease is in the anteroinferior part of middle ear and eustachian tube. No doubt, the middle ear cleft being continuous with each other, the whole of the middle ear cleft is affected in this infection, but main burden of infection in tubotympanic disease is in the anteroinferior part of the middle ear and eustachian tube, which is apparent from this picture, beautiful picture of middle ear cleft. And that is an oral polyp which is visible to you in the external auditory meatus as a reddish, smooth mass filling the external auditory meatal cavity. That is another oral polyp, and this is the oral polyp which has been removed from the external auditory meatus. Another oral polyp which has been removed. And let's go back to our lecture. We were discussing the signs, and discharge is present in the external auditory meatus, and after cleaning the discharge you see the perforation and oral polyp might be there. These are findings on examination. Investigations which we can do in these cases is the X-ray mastoids, which is X-ray mastoid comparative. Mostly we perform on a single X-ray film. We picturize both the mastoid areas, right as well as left, for comparison. It's basically X-ray mastoid oblique view, showing you the area of external auditory meatus and behind that the mastoid process. And in this X-ray, in case of tubotympanic disease, you can appreciate that the mastoid air cells, they are also looking hazy as compared to a normal pneumatic X-ray mastoid. The mastoid over here will also be hazy because of persistent chronic infection. We can send the pus for culture and sensitivity to select proper antibiotic and give it for proper length of time so that the infection is clear. So whenever there are facilities available for culture and sensitivity test, that must be performed, because that is the proper method of using antibiotic and will be more effective. Pure tone audiometry, we have already talked about conductive deafness, to confirm the presence of conductive deafness and to know the amount of deafness, the quantity of deafness. This pure tone audiometry can be of help. Examination under microscope can also be performed if you are not sure about the findings, or you are in a doubt about your examination findings, you can confirm these findings under magnification by microscopic examination. Now the treatment. Treatment is medical as well as surgical. Obviously, first we try to give medical treatment to the patient in a hope that the patient will recover with medical treatment. That includes oral toilet, obviously, repeatedly cleaning the ear, and you can use local antibiotic drops. Antibiotic drops, they are available in various forms. Different antibiotics in the form of drops, they are available in the market with or without steroids. The antibiotic in the drops obviously will be responsible for cleaning the infection, but the steroids, they have got their anti-inflammatory role as well as antipruritic role. There is no harm in using local steroids in these cases in the form of drops with antibiotic, giving better recovery and early recovery, except for those cases where you suspect suppurative fungal infection. In those situations, we try to avoid the use of steroids in the form of oral drops. And systemic antibiotics, as we have talked about the culture and sensitivity test. After getting the report of culture and sensitivity test, you can give the patient proper and effective antibiotics. But before that, it's also a usual practice that the ENT surgeon, by his own experience, practical experience, he can start the antibiotic after taking culture, and when the report comes, he can make certain changes if needed. Antibiotic in these situations must be given in proper dosage and proper length of time. Many times we find cases coming to us, Doctor Sahab, we have used this drug, we have used that drug, but still the patient is not getting recovery. And when you inquire, you come to know that the antibiotics which were used by the patient, either as self-therapy or taking a few doses of antibiotic from the chemist shop, or antibiotic given by a quack in improper doses and very short time, which are the reason of failure of recovery in these cases. The antibiotic must be given in proper dose. Selection of the antibiotic should be proper, which is effective against those organisms responsible for causation of the condition. And the length of time for which the antibiotics are to be utilized, that is also important, because these are cases of chronic suppurative infection. We may need the antibiotic for a couple of weeks or even sometimes a bit more. But practically what happens is, when the patient starts using the drug, after a few days when he feels the recovery, most of the time he stops taking drug without consultation of his ENT surgeon. And that is the most important reason for failure of medical treatments. So this should be kept in mind. The antibiotic which are used, they must be used for proper length of time, proper dosage, and proper selection of the antibiotic must be done. Many patients, they recover with this medical treatment if it is done persistently, and afterwards when the ear is dry, we advise the patient to keep it dry. There should be no entry of water in the ear while taking bath, because the bath water is not sterile and there is a perforation in the drum, and that non-sterile water can easily enter through the perforation in the middle ear cavity and is responsible for reinfection. And this is perhaps the most important reason for recurrent infection in these cases. So the patient must be informed about that. Such a patient also cannot enjoy swimming unless the air is he uses the earbuds, which do not allow the entry of water into the ear. Otherwise, he cannot use this facility of swimming. So we advise the patient either not to swim, or if at all he is very fond of swimming, then he will have to make the ear first safe, no entry of water, and then he can do that. Most of the time the people ask me how to save the ear from entry of water during while taking bath. Truly speaking, if you are a bit careful and your hair are not that long, properly trimmed, and while pouring water on your head, you keep the head straight and erect, the water does not enter the external auditory meatus because of natural anatomical protection given by nature. But still, if you cannot avoid that, then you have to use the earplugs preferably, or if that is not available, you can put a piece of cotton in the ear and cover it with some wax, polyfax or something like that, so that this cotton is also not getting wet with water, and after that you can remove it after taking bath. So this is a very important part of medical treatment, otherwise the patient will have recurrent infection. If in spite of proper medical treatment the patient does not recover, then we'll have to go for surgery. The surgery includes, if it is oral polyp formation, you can do oral polypectomy and give the patient medical treatment afterwards. For 2 to 3 weeks the patient may recover. But if still the infection is persistent and is not responding to medical treatment properly, then we have to do what you call it mastoid exploration. Mastoid exploration, in which we explore the mastoid antrum and reach the mastoid ear cells and clean the area. The mastoid exploration is of 3 types: cortical mastectomy, modified radical mastectomy, and radical mastectomy. We will discuss this in the next topic of aticoantral disease.